For sure.
Okay, I think Darshan, you can introduce him and we can start. We are now already 360
Okay.
participants. I think we'll go over 400.
Good evening, everyone, and very good morning to Mike. On behalf of Fine and all everyone attending this webinar, I would like to thank Mike for agreeing to participate in this learning session. Dr. Michael Hill does not require any introduction. He has been a fantastic stroke neurologist, a great mentor, and a great researcher as well. He has been a principal investigator in multiple landmark trials like the ESCAPE NA1. Endovascular therapy forms a cornerstone in management of acute ischemic strokes. And I feel Dr. Michael Hill is the right person to share his views on this. Over to you, Mike. Thank you once again for participating in this.
Okay, well, thanks, Darshan. I just want to check on the chat. There's someone who's written that they can't hear. So, can everybody hear me well and see the slides?
I think everybody will be here. Darshan, you can close.
Is everything okay?
Yeah.
Okay, I put the chat open. So
Michael,
you're okay. Okay, so I'll go ahead and start then. So thanks a lot. Darshan and I know each other well because he spent some time with us in Calgary.
Michael, sorry, 1 minute. I'm just interrupting you.
Yeah.
I think drag those windows onto your screen. Don't keep them because they're blocking your.
They're in the way for people. Ah, I see. Okay.
So you can remove that.
Just get rid of those.
Yes. Both.
Just there we go. There we are. Okay, is that better?
Yeah, perfect.
Okay, thanks, Sudhir. So just to say, as I said, Darshan and I know each other because Darshan spent some time in Calgary, and it was terrific to have him with us. It's now more than a year, I think, since you've been back. So here's a picture of Calgary when it's sunny and people are actually outside and not isolating for the virus. There's some disclosures for me. We've had lots of different sources of funding over the years in our group, and so I just put some private industry and some public funding over time. And so what I thought, I spoke with Darshan and Sudhir just yesterday actually, and I thought I'd just go over, about what we're doing in acute stroke, give you some examples from Calgary, and go over some of the data. And I'd like to start by showing this lovely picture from our colleague Al Jin, who works in Kingston, Ontario, here in Canada, where you can see he's holding someone's head in the scanner, and you can see his wedding ring on his finger on the side of his skull. So just a kind of a fun picture to show a hands-on approach to stroke in terms of getting imaging. So I'll talk a little bit about data, some stroke assessment, imaging. And I'd like to spend a little bit of time at the beginning talking about, treatment with intravenous alteplase, and then I'll jump into the endovascular data, and we'll spend the bulk of the time talking about endovascular treatment and some of the data that's out there, what it means, etc. Right? So I'm going to start with a little bit of a poignant story here. This is a picture of Chris Lewandowski. Chris is a colleague. He's actually an emergency physician, and he works at Henry Ford Hospital in Detroit, and he was the main or one of the key principal investigators on the NINS TPA trial. So he was, his sort of mojo was that he felt that he had substantially contributed to the curing of stroke because TPA could make people better and the like. And yet, in his own specialty, even in the United States and even around the world, there's been a lot of pushback on the use of TPA. Many of the emerge docs have been shy to treat, right? So and the sad part of this story is that despite his enthusiasm and stuff, his father developed a stroke in Wisconsin, which is about 6 hours drive from where he lives. And he got called on the telephone early, an hour, 90 minutes in or 2 hours into the stroke. And the emergency physician had said he wasn't going to give his dad TPA because he didn't believe in it. He didn't believe it was right. And unfortunately, Chris's dad later went on to die. And so Chris tells this story as one of the biggest problems we have is not so much that we don't have treatments for stroke, is that people aren't using them. And so it's a poignant story, and Chris is a terrific guy. It's just a sad story towards the end of his career that this happened to him. So as Darshan will tell you, my mantra is get on and treat people, right? Because I just think it's such a terrible disease, stroke, and we have to get out there. So give the juice. We have lots of data, as you know. This is a little bit of an older slide. I haven't had it updated because we even have more data from now, but there's lots of trials out there. Thousands of patients have been randomized. These are all the TPA trials. And we know some clear things about the use of thrombolysis, which is that we have to be fast. So speed is critical. And here's the clinical manifestation of the time thing, which is, and remember, one thing I would tell you about this graph, and you've seen it, if you're a stroke doc, you've seen this graph multiple times, is that this is a modeled line of the data. And in fact, if you look at a scatter plot of all the points on the data, and I don't have it for this data set, this is the Emberson meta-analysis, individual patient meta-analysis, but the scatter plot is all over this line. So the degree of variance, it's not true, for example, to say that all the points are scattered around this line. It just is not true. The degree of variance in inter-individual variance is very, very high. And that leads to some of the things that we talk about in terms of late window treatment, and I'll get to some of that later on. But generally speaking, right, you got to treat someone early. They have a better chance of doing well. Treat them late, and the lower, on average, the average population thing is that if you're on beyond 5 hours, you're not going to get much benefit. But the point I really want to make is that as an individual patient, some people you can treat at 8, 10, 12 hours from onset, and they really obviously benefit from therapy. Here's the sort of nice manifestation of or way a different currency of talking about acute stroke. Jeff Saber and his team did this work based on serial MRI in patients with proximal middle cerebral artery occlusion. So this is based on the large occlusions, right? You 2 million neurons a minute, 14 billion synapses, 12 kilometers of fibers. And in some ways, this is also a testament to the actual number of neurons we have in our brain. It's trillions. So we have, and that's why so many die so fast. But it's a staggering number, and it really helps as a way to talk to people and say, get moving, because we're trying to save brain here. We have this general problem in human nature. All teams, everybody, physicians, nurses, paramedics, and ambulance folks, and everyone involved, DI techs, etc., is that when we think we have time, we take more time. So these are Canadian data from 15 years ago, maybe, but still a poignant illustration of human nature. So if the patient arrives at the hospital onset to door, right, and they arrive quickly, say under 50 minutes, right, under 50 minutes here, looking along here, it takes 100 minutes to treat them, right? Whereas if they arrive really late, 150 minutes, you can get them all treated really quickly really, really fast. And of course, in general, what we want is to treat everybody just as fast, no matter what time they arrive at the hospital. Our intra-hospital times need to be consistent and fast. And this was first shown by the group or published and, made a statement, right? The group in Helsinki. So it was Ate Maritoya and the group in Helsinki said, look, none of this messing around. If we're going to treat people, we got to do it quickly. And so you can see here is their data going back from 1998 all the way through to 2011. You can see the line shows the falling average times from hitting the door to getting treated, and in parallel with that, a rise in the number of patients who are actually treated. So and it's just amazing. You can do it basically, and so we in Canada, what we did is we got everybody together and said, look, come on, we got to have a statement out there, and we put this statement out to say, really, everybody should be treated under 30 minutes. None of the 60-minute kind of timing. We should be treating quickly. We should be treating really quickly. And then the other, I put that NNT equals 5 up there on the left to show, or just to, we put together a paper from the the control group in the Hermes analysis to make the point that if you treated under 30 minutes, you were able to, you had one more extra good outcome compared to treating between 30 and 60 minutes. So for every 5 people treated. So that means, I mean, in real world data, if you treat one more patient faster, you treat 5 more patients under 30 minutes, you get 1 extra independent outcome. So it's very, very powerful. Like an NNT of 5 is an amazingly low number for treatment. Okay. You guys. Okay. Sorry. So then the other thing that often happens when we're talking about thrombolysis is people are all fussed about risk, right? Risk of bleeding in particular. And it's not, it's not a zero-sum game. So you have to be aware of it, of course. There are contraindications of thrombolysis, but I think you can narrow it down and be sensible, right? That the risk of bleeding is actually quite low. And there are 2 absolute contraindications and everything else is relative. So the first contraindication, you guys, that the patient's bleeding. So obviously don't give them a thrombolytic if they're bleeding. And the second is they're about to bleed, right? Or they're high risk for bleeding. And you can judge that issue of risk depends on a lot of things. So for example, recency of surgery is a relative thing. It depends on how recent and what type of surgery and that kind of thing. And the same thing for things like hypoglycemia, or if there was a seizure at presentation. If you have a seizure, but you have an occluded M1, you're still going to go and treat the patient, right? Because we'll see things like that. So I think it's important to be sensible about this and use your clinical common sense. So I teach the residents and others and the fellows and things to try to distinguish between what are written down as apparent regulatory rules, all of which were derived from clinical trials. And you have to realize that the clinical trial criteria were designed to make the clinical trial effective and to show an effect. They weren't necessarily all applicable to real life medicine. So we have to be thoughtful about that. And we can use our knowledge of the pharmacology and the biology of drug effects, half-life, et cetera, to help us understand that risk. Okay. As we're winding up the TPA stuff, I really like to show this slide when I talk, because these data are I think they're the only data of this type really available from a randomized trial. And we did this in the ESCAPE trial, where in that trial, you may recall we were randomizing patients to endovascular therapy or control, and they received intravenous alteplase in routine care according to whether they were routinely eligible for treatment. So in this, and then what we did is of course, in the intervention group, we had an angiogram to tell us what had happened to the blood vessel and the thrombus in the artery. And in the control group, what we did is we did a control CTA at 2 to 8 hours post-randomization. So you see down the bottom here. And what you see, now be wary that the TPA and IVTPA and no IVTPA groups are non-randomized, of course, because that was decided by clinical routine. So the groups are different. But still, the numbers are large enough here that I think it's meaningful to understand. So if you don't give intravenous TPA, and remember all of these patients had an M1 occlusion or a top of the carotid occlusion, you do get a recanalization rate. It's about 7% here measured. And so we would have called that in the past the spectacular shrinking deficit, or sometimes the therapeutic CT, right? You take them to scan and they get better because they spontaneously reperfuse. And you'll see that occasionally. And of course, that's terrific. Patient gets better. If you give alteplase, you will get improvement. About a third more people will show recanalization on their CTA. So this is important. It's interesting though that it's often incomplete, right? You get a partial opening, you get distal migration of thrombus, and that kind of thing. So it's not perfect, but you definitely get opening of the blocked artery only in a third though or so. So the truth is that for large artery occlusions, it's just not good enough. And then you need endovascular to get you above the 70% range, right? And the difference here is just randomness in a small sample. Because remember, we only had 315 overall in ESCAPE, but now we're getting numbers in the 85% range for post-intervention EBT. So So really, that's the distinction, right? It's good, it works, but it's not good enough, and that's why we need the endovascular stuff. Another interesting pieces of data that we've been able to piece together from stuff, and I think we saw. I don't have slides from Bruce Campbell's work in Australia on tenecteplase to show you, but this is just an example from ESCAPE. You can see that there's about a 3% increase. Now, in the CTA was occluded, and then we gave TPA and went to angiogram, and you do see there a small number of patients will completely recanalize with the TPA and then don't need endovascular intervention. That's very fast, right? When we were in this trial, we were about 45 minutes from TPA to reperfusion in the cath lab. So overall, the teams were incredibly quick. In Bruce Campbell's data, where they gave tenecteplase at a primary hospital and then transferred the patients for endovascular therapy with about an hour in between, there was a much greater 20% reperfusion rate or recanalization rate with tenecteplase. So I don't necessarily think it's the drug. I think it in part is the time difference between the two. A really important thing to remember is that in terms of deciding whether you're going to give TPA, and as you know, there are some trials looking at withholding TPA, and they're ongoing still. But we're not perfect at getting arteries open. So even in the Hermes group, we were only 3/4 of the time did we get the artery open. And one of the things I've always said to the residents and fellows and stuff is that, if you can't get the artery open, or a quarter of the time you're not going to have it open, you'll be really upset if you didn't at least give TPA to try and help this patient. Even if it only works, 10, 20 or 30% of the time, you want to give them a chance for treatment. And finally, there's a very small percentage here. Look at this set of bars here on the left, where you can show that you get one of the advantages of having a thrombolytic on board is that you get distal emboli cleanup. Right, so this is the group that the 1.1% are the infarcts in a new territory in the group that got TPA versus the group that did not get TPA. And so we think that there's some observational evidence that the concept that having a thrombolytic on board at the time you're doing an intervention actually helps because you deal with the distal emboli. And finally, there's not much safety benefit whether you give TPA or not. So it's 4% overall Hermes group, 4%, 4% major hemorrhage rates, and we didn't see a big change. So it may not be true that withholding TPA is a substantive benefit in this way. So I'm still promoting the idea that we want to have thrombolytic on board as much as possible. I think we're going to see a little bit about those trials that are pending, Mr. Clean Direct and things like that on Swift Direct are being done to help us understand if that would we could withhold alteplase. One general problem with those trials is that they're all small, and so if there is a small difference between a small benefit of having a thrombolytic on board, and I suspect it is relatively small for large vessel occlusions, we may not be able to detect it. So I'm not clear that those trials are necessarily going to be definitive for us to help make these decisions. We'll have to see. So the other recent developments are things like, trials that have looked at this scenario. Excuse me. So this is Goetz Tamala's work and Jens Fieler in Hamburg. And they did this trial looking at using MR to treat so-called wake-up strokes. And this is getting at the whole time issue. And I'll refer you back to my initial comments about the fact that there's so much variability around that timeline, suggesting that everything should be done based on a threshold of time. And these trials, there's wake up and a couple others I'm going to show you in a minute, suggest that that's not true. So in this trial, they look at stroke on awakening. They did MRI, they randomized to TPA or not, and they clearly showed a benefit. Here's the scores on the Rankin scale, so 0, 1, 2, and you see there's a clear shift. In the alteplase group, patients are doing better. But there's a couple of key things about this trial that are important, right? One is the volume of stroke on the baseline imaging was incredibly small, right? And this gives you terrific safety, a terrific safety profile, right? If you have small strokes, you give them thrombolytics, they're not gonna hemorrhage, and that's really key. And so that, I think that was probably the most important aspect. Interestingly, they didn't have big strokes. You know, we're not talking about people with wipeouts of NIH of 20 and that kind of thing. And so it's a really interesting result. In general, though, I think I'm going to show you the Dawn data in a minute, the same thing. And an important thing to consider is that stroke on awakening is a bit of a misnomer, because we often don't know when a stroke started. Particularly, it's really about whether a stroke's witnessed or not. And I'll tell you, interestingly, from Escape NA1, they don't have a slide on this, but only 55% of the strokes were actually witnessed. So we have witnessed and stroke on awakening. There's a lot of stroke which occurs where there's not somebody there to identify the exact time it occurred. And even if there is somebody there, people are not necessarily good witnesses to the timing, right? Something crazy happens and people get all excited and they don't notice the time. So I think that the true issue is we're going to be gradually abandoning time, and we're doing it here, where we've largely abandoned time as a critical variable. It's just a variable that we're using. So you'll know the Dawn trial, which was run by Raul Noguera and Tudor Joven, which was an intervention trial, and they looked at a 6 to 24 hour window. They used a combination of CT, MR, CT perfusion ways of selecting patients. It was not don't think this was a trial which was all about rapid and use of CTP, because it certainly was not. Many of the patients were not enrolled on that basis. They had started for a sample size of 500, but they stopped early. And look at this. This is to get you at the stroke on awakening side. This is really interesting, right? So if you look at the unwitnessed stroke and the stroke on awakening, you're looking at 90%, and here 85% of the population. So a really important concept about Dawn is that this really wasn't a trial of a 24-hour window. This was actually a trial of unwitnessed stroke onset. And I think that's probably the lesson that I really take out of this, is that it's not necessarily true that it's about time. And so I think the concept here is that we should largely abandon time as a threshold for deciding if we should treat, and instead use imaging, which is what this is about. The Dawn trial was remarkable. It showed an amazingly large treatment effect, and you can see here that in the intervention group, 50% of the patients approximately had a good outcome, and 48%. But what's interesting here is, if you think about it, 50% good outcomes is about the same as what we saw in Escape and Swift Prime and others, right? It's not true that somehow the effect size was, or the absolute numbers of people doing well was good. What we did see, though, is that in the control group, people did incredibly badly. So it means that, even if you have an unwitnessed stroke and you got a big artery occlusion and you don't treat them, right, they're gonna do really badly, right? So that's the lesson of the Dawn trial, right? It's not a as touted, somehow we can use a 24-hour window threshold. No, it's about unwitnessed stroke, using imaging to decide that the patient's in a has salvageable brain, and then getting on and treating them quickly. And then subsequently, as you know, we've had Diffuse 3 come out, and I don't have slides for that, unfortunately, to show you, but just to point out that in that trial, they used a 6 to 16 hour window, same thinking again, but it largely got the same result as the Dawn trial, and the same concept that the control group did very badly. The intervention group, about half the patients did well with intervention, and they did use CT perfusion and MR perfusion to select patients. So it was a combination of those things. Really interesting. And then finally, you've seen ECAS-4 and the Australian Extend TPA study, both very small studies, all with a direction of effect suggestive that there's benefit giving intravenous thrombolysis, again based on imaging, and so it's the same principle. And so we moved to this model, something which I can tell you in Calgary we've largely adopted for many years, which is what I call the so-called good scan occlusion model. So you ignore time, and you use time as a as just another variable in your overall assessment of the patient. Just like someone's got diabetes or they don't, or they have hypertension or they don't, right? Or they're 85 or they're 65, whatever it is. It's just another variable. But the key thing is to look at the imaging and understand, do you have a blocked artery? Yes. Do you have a good scan? And there are many instances I can tell you where actually all you need is a high quality non-contrast CT scan, and then you can make a decision, right? You don't have to rely on multimodal imaging, which in many cases is just going to delay what you do. Now, there are certainly times when it's really helpful, and in general, I can tell you that in our place in Calgary, we routinely do non-contrast CT and multi-phase CT angiogram on everybody. And that really helps us because the multi-phase CTA gives us where the occlusion is. And then by looking at the collaterals, you get a really good assessment of what the structure of the perfusion is. And it's going to really help you. We certainly do use CT perfusion and rarely MRI. Probably about half the cases we're using CT perfusion on, I would say. Overall, my personal experience is that it's incredibly rare that CT perfusion changes my mind about what I'm going to do with a patient. So I've largely personally abandoned it because I don't think it helps me at all, and it just delays me another 5 minutes, 10 minutes. And there are lots of times, plenty of examples we've had where certainly with and Darshan, you'll remember how fast Mayank is in the cath lab, where we've done a CTA, moved the patient very quickly to angio, and Mayank has already got the stent up by the time the CT perfusion processing has been done. So I've seen amazing results where treatment is the best way to go. Move quickly. Now, you guys have available, I think, a biosimilar tenecteplase in India, which we don't have. But there are these trials going on with tenecteplase that look very, very, very exciting. This is the first phase 2 trial of TASTE, which Mark Parsons led in Australia, and they're doing a follow-up trial. I think they're at about 470 patients enrolled in that trial now. So we're going to get information from that. You've seen, I talked or mentioned briefly Bruce Campbell's work looking at the drip and ship paradigm. Give tenecteplase in the primary hospital, then put the patient in an ambulance, send them for endovascular therapy to a tertiary hospital. And this is the key thing, that about 10% of the group recanalize, not necessarily reperfuse, because there's a lot of distal migration of thrombus. And then about double that number in tenecteplase. And since that time, Bruce presented in February the Extend IIT-NK Part 2, in which he compared tenecteplase and tenecteplase, so 0.4 versus 0.25. And he showed that 0.25 milligrams per kilogram was just as good as 0.4. I think everyone has sort of set around the world is settling on the concept that 0.25 per kilo is likely the best dose for patients for patients with stroke. Okay, here's a little fun. Have a read through that. It's just a little bit of tongue-in-cheek fun about all the medicines we use. So here we go. And that's a bit of a break. So there's my summary of alteplase. All right, get on with it. Give the juice. Right. Okay, so let's move on to endovascular, and we in North America, we call it EVT. I know in Australia, they've called it endovascular clot retrieval. But anyway, that's just so you know the differences. And I'll just go through some of the trials. And I'd like to just focus on some of the practical things about what you do here. So, I mean, lots of trials here, right? We were able to pool the results into the Hermes group. And there's lots of nice papers that have come together. And I think it was a really good exercise overall when I look back on getting everybody to work hard to pool the data, because the trials were all in the few hundred each. And so by pooling it all, we were able to get numbers in the thousands. And that's, I think, really helped us to understand some of the subgroups. And that was the whole goal of it. And I think it's been a really nice collaboration. Here's the first 5 of them. And I think what you see here is really that the effect sizes were incredibly similar overall. And so this is a great example of how important consistency of epidemiology is, right? So when you have multiple studies all done in different places around the world, all showing the same thing, it really argues for the consistency and the truth of the biological effect that opening an artery is a really, really good idea in ischemic stroke. So obviously that in Hermes, the initial trials mostly used stent retrievers. It was about 85% or so. First device chosen was a stent retriever. And I think there are lots of different people who argue about the best approach, but the bottom line is it doesn't matter as long as you get the artery open well and you're not causing complications. All the trials had some mechanism of identifying a blocked artery. Some used CTP, CTA, MR. The French group used MR, for example. And that's what happened, right? And so it's published there. The overall effect size is very large. Remember, NNT of 2.6 is to me it's a little bit contrived. The NNT is between 4 and 5. That's the bottom line, right? If you did it in the traditional way, right, which is one more. If you treat 4 patients, 1 extra patient has an independent outcome. 2.6 is trying to give some estimate of the whole range across the Rankit score. So it's not the classical binary way of deriving it, and so it's an interesting, but it's a derived kind of number, and it's a little bit more of a treatment effect showing this. There is a time effect in the Hermes group data, which this is onset to arterial puncture time, and you see that there is clearly a time effect, and once you get at 7 hours or so, again, on average, I would again remind you that in these time graphs, the scatter plot around this line is dramatic. There's incredible inter-individual variability, which is why you see at the Dawn trial and Diffuse and Wake Up, they're treating people with this kind of onset to puncture time, and you're getting good outcomes still. So that's just about selecting the right population. Here's another way of looking at it, which is that the NNT starts here, and then by the time you get up to 6 hours, 7 hours, 8 hours from onset, the benefit starts to fall off, right? There's again another way of looking at the time. You can see that in epochs of time, you see gradually more mortality as time elapses, and you see less and less and less benefit as time elapses. So same principle. It's just showing you the actual breakdown of the data, and these are actual data, and what you saw before were modeled data. So let's get into some of the particulars, because I think this is where some of the technical details we fuss about and worry about. So here's a really important one. So should you use general anesthesia or not, right? And this is interesting because there have now been some single center studies. So the first thing that happened was that there was a number of cohort studies which suggested that general anesthesia was associated with poor outcomes compared to non-GA. And one of the key observations, I think, was that when you induce somebody, right, you intubate them and paralyze them and the like, the first thing that happens is they drop their blood pressure. Often for 10 or 15 minutes, the blood pressure is low. And when you have that scenario physiologically with a blocked M1, you accelerate infarction dramatically when the blood, because you basically drop off all the collaterals, right, when that happens. And so I think in the cohort studies, it was absolutely clear that GA was worse, so there were poor outcomes. And so subsequently, 3 small single center studies have been done. They're all small and they're all related, and all were done in Germany. And I'll tell you the interesting thing about them is that what they compared is GA to conscious sedation. They didn't compare to no sedation at all. And I think there's a judgment that's required. But I can tell you that in Calgary, and even in the ESCAPE and the ESCAPE NA1 trials, which ESCAPE NA1 we just completed, a very high proportion, like 50% of patients required no sedation at all. The procedure was just done, local anesthetic in the groin, arterial access, and then off you go. And this I can tell you even in Escape Anyone, we've not published this, but I can tell you the data. The patients who had GA did worse. And the centers that used GA routinely had worse outcomes than the centers that did not. And I'm not convinced that the patients were substantially different. And so I think that the jury is still out on this. I think if you're going to use GA, you got to be awfully careful here, right? One is you really need to have incredibly careful management of blood pressure, and you need to hopefully extubate the patients at the end of the procedure, because keeping them in an ICU on a vent is just exposing them to the possibility of ventilator-associated pneumonia and then poorer outcomes. Now, for sure, some patients, you can't do this procedure without GA, particularly, for example, a basilar occlusion, or sometimes often a young patient with a left MCA stroke with a Wernicke's type aphasia. They're very agitated, and there's no way you can manage without. So you're going to have to use judgment. But I think I still worry about the idea that GA may well be to some degree toxic and negative to the brain, and we have to be careful about this. That the data is not sorted out. The final thing, though, that's going to, the balance is that as we start to go after more distal occlusions, in order to get complete reperfusion, you need to have a still patient. There's just no doubt about it. It's too dangerous to be putting catheters in an M3 and we may need to have GA for these cases. So I think we just have to watch the data carefully. For now, for the typical proximal M1 occlusion, if you can get away without GA, you're going to get better outcomes overall. So there's the data from Hermes. Now, again, it's a case series in a way, right? Because they're not randomized to GA or not, but the data are pretty remarkably consistent that if you got GA, you did worse. And I don't think it's all confounding by indication. I really don't. But I don't know how much is the confounding by the agitation and the more severe patient, and how much is something that GA does. We just don't know that. One thing that's clear, though, and this is an important point, is it doesn't mean you shouldn't do the case. Like if you have to do GA, you should still do the case, because the GA arm here is still doing better than the control arm, right? So you know that it's just one of those factors, but you should still go open the artery, right? Now, reperfusion, really important. And I think this is a technical thing you should talk about. Just look at the gradation here this is Dave Liebeskind put together a terrific sort of really granular scale of what the reperfusion was like, and he's called it E-TICI. It's published. It's just a modification of the M-TICI, but you can see going from 0 all the way up to 3. And the bottom line is that the more you can get full, complete reperfusion, the better the patients are going to do. So I think that there is a technical side to this procedure. The stent retrievers and catheters that we have now are just terrific. They're eveners in terms of technical ability, for sure. They allow people who aren't as technically good as others to do this well. But still, I can, even in our own group, I can see differences in how well people use them and how well they get access. So, a really good interventionalist is going to have greater ability to get TICI-3 fast. And that's going to result in better outcomes overall for all of your patients. And I think it's important to recognize that stopping at TICI-2B or TICI-2A may not be appropriate, right? And there's some judgment required, but the best outcomes are achieved when you have a high quality reperfusion. Okay, let me talk about minor stroke that people are, worried about. Should we be going after the M2s and M3s or P2s? Occlusions, right? The lower NI stroke scale scores. And the truth is that right now we don't know. There are very few data looking at this. A few patients were enrolled in Mr. Clean, and there's been a proposal to do a trial in this area. And we're proposing to do a generalized trial. We're trying to work this up right now. We've called it medium vessel occlusions, and in part the relevant companies are now starting to produce smaller stent retrievers that are potentially useful for dealing with some of these small occlusions. And so we're going to look into seeing whether we can actually do a trial in this area. But there's a lot of controversy, and I think obviously there's a lot of enthusiasm amongst interventionalists to go after these things. But you know, when you start looking at the data that have been published so far, there is potential for harm, and I think that's a really important thing to think about, right? We've certainly seen in a couple of series, Nagar Asdagi put together a series of a whole bunch of cases from Florida and Puerto Rico in the United States, and clearly showed that there was actually harm here in going after small things. So we have to be careful about this. I think there's you know, the balance there needs to be thought through. There's a nice, let me just see what I got here. Oh yeah, this is just to show you some I just want to show you some pathophysiological data from Bruce Campbell. Bruce did this lovely analysis, and Bruce did this as well as the Dutch group, and Mr. Clean group looked at Hermes and just showed this nice relationship between the size of the final infarct and the outcome. And so what you see here is the gradation of outcome. And it's interesting though that infarct, you know, in the actual infarct volume, only, if you look at it statistically, is only a part of the overall clinical outcome. It's not the be all and end all. It's certainly a great technical indicator of how well the reperfusion is and how fast you were and all that kind of stuff. But the overall patient outcome will also depend, of course, on other things like how old they are and what was their functional status beforehand and other comorbid illnesses and that kind of thing, right? So clinical outcome is just a component of the infarct volume. And you see that here. Statistically, once again, you can show nice relationships between the infarct volume and final outcome. Interestingly, here you see that in the control group, you know, people don't do as well, and of course, if they in the endovascular group, much better with smaller infarcts, right? And you see here, I mean, it's the same thing. Those are just the raw numbers. I'll skip through. So you can see it's a strong predictor, but as I say, it only has a, if you do this thing called mediation analysis where you're trying to understand what's the relative contribution of final infarct volume to the overall functional outcome, you can see it's only accounts for about 12% of the variance. So that's important. Okay, what about low aspects or you know, someone who's already got a reasonably large size infarct? Should you be taking them to intervention? And I think we have relatively sparse data because all the trials were done with a physiological concept of the kinds of patients that we ought to be enrolling in these trials, and so we excluded people with large cores, low aspects patients from the trials that were done. So the Hermes data do not contain a lot of information on these patients. So again, you're using your judgment about this. We do have a fair amount of data from the early medical thrombolytic trials, right? So the MAST-I and MAST-E trials, the ASK trial, et cetera. And they all essentially, and even ECAS-1, where it was clearly shown that if there was a well-established infarct on the scan, you know, that the drug TPA was bad, right? It clearly was associated with more hemorrhage, and more importantly, there was just no benefit, right? Because the infarct is already done. And my guess is that we're going to show exactly the same thing with, I mean, everyone's after it right now with, you know, there's tension and a few other trials being done looking at this, but I can't foresee, to me, that if there's already a big stroke, that reperfusing it's going to make a lot of sense. The brain's dead and you can't make it better just by opening up an artery, right? So we're going to have to see. I think there'll probably be some benefit around the edges. People who have, say, an aspects of 4 or 5, and you know, maybe it's in the right hemisphere and it's in the temporal parietal region, a bit more silent, and they've got essentially an autologous temporal lobectomy being done by their stroke. They may do okay, right? And you guys have seen this. Each of us probably on the call here has seen a case of a big right MCA stroke that did well with hemicraniectomy, you know. So here's an analysis that Bijoy did in our place on the Hermes data, just showing that, you know, there's still benefit even in this group here, probably on average, but once you get down with a big wipeout stroke, it just doesn't make any sense, aspect 0 to 2. But look at the numbers, 37, right? So you're not talking, I think you would just be very, very cautious about interpreting what the statistical data mean. I'm going to skip through this for a minute. I just want to show this. This is a nice, coming towards the end here, and I just wanted to show, this is data that Bruce Campbell put together, which I think it's lovely information. Sometimes difficult to interpret, but just showing the relationship between large infarcts and age, and then how fast you got people going. So sort of the bottom line is that the smaller the infarct, the better you do. And the color coding here is the Rankin score. You can see how he's done it. But as you get into big infarcts and you're older, so here is the age criteria, nobody does well. So, if you've got an 80-year-old with an aspects of 3, don't take him to the cath lab. There's no point in doing that. It's not going to do any good, right? The patients are just not going to do well. And whereas a younger patient with a big infarct over here, so you take a 40-year-old you may still be able to salvage them. And so there's this clear relationship between the impact of large infarcts and the age of the patient. Again, totally common sense, right? So we're going to see. We've got a couple trials going on here, and I think they're going to be incredibly challenging to do these studies because there'll be so many adverse events. A lot of people will die, and we're going to see. It's the same as the CHARM study, which is looking at glyburide in these big strokes. Practically, when you're one of the things that we really like to work on is our whole system, right? So it's not just what you do in the hospital, it's what's happening in the community as well. And so we've been teaching the paramedics about how to treat people quickly and then get them in, and then we're triaging them as fast as we can directly to CT. A large majority of stroke patients are going to be stable. They're not going to need intubation, at arrival at hospital and stuff like that. So probably 95% can go straight to CT. And so we've been doing that recently. We've had to modify everything recently because of the COVID-19 stuff, but we're looking for a 5-minute door to CT time. We use point and shoot CT, not helical acquisition. Our experience is that helical acquisition of the non-contrast CT provides inferior image quality and tissue resolution. The helical aspect of CT is fantastic for angiography and CT perfusion, but we resort to the old style single plane acquisition for NCCT, and then we do a multi-phase CTA, and we get this kind of these kind of pictures, right? So here's a plain CT, and then there's a blocked artery here. We can see that on the second phase and third phase, we can see the collaterals filling in nicely, and then we make our decision. In general, you find this kind of thing. Our experience is that you see the cerebral blood flow. It corresponds here. You can see the downside, but it corresponds really well to where the collaterals are filling in. So again, doing this, I guess I've been fortunate because I've been able to do. Had experience looking at multi-phase CTA and CTP, and I find that the multi-phase CTA tells me everything I need to know. And then you get the artery open quickly if you can. Try to get TICI-3 reperfusion, and when that happens, you can get a completely normal diffusion lesion, MR afterwards. So it's totally possible to salvage people dramatically, right? As I say, we rarely are using GA in Calgary. I use this kind of approach to manage the conscious sedation. Midazolam, fentanyl, typically, you can just give it boluses 10 minutes, 15 minutes apart, and most patients are just fine. If we need to use propofol, I use really low doses, 20 milligrams, et cetera, and be aware that propofol can be quite a significant negative inotrope. So be aware that sometimes even with low doses, you can get low blood pressure. We've used ketamine as well, although that's a bit of an uncertain choice, and you have to be careful because it does also affect blood pressure, often gives a hypertensive response. So be careful. And remember this is an old adage from one of my own mentors when I was training, which was on the internal medicine ward, is blood pressure is king, right? So remember that that, you know, you've got to have a blood pressure, or your patients are just, you know, it's not going to, if you got 15 minutes of a blood pressure of 50, you're done. You might as well stop, because all that brain's going to be dead. So use phenylephrine and other things to keep that pressure up as you need. Post-op, it's really useful if you have if you've not had to intubate, because then you don't have to, excuse me, then you don't have to worry about all that post-op care. So we usually the blood pressure comes down spontaneously. We run normal saline. We follow the patients carefully. One thing to be aware of is if we've had to stent the carotid artery because there's significant atherosclerotic disease in the carotid, then you can run into problems with bradycardia. So make sure you have atropine or glycopyrrolate available, and watch that. I mean, you may need to monitor the patient just for their heart rate, but it's not super common that occurs, right? We have to make sure you have Narcan available. I've certainly run into trouble where I've been over enthusiastic with my conscious sedation and then needed to have some Narcan. So that just be aware of that. And then the last thing are simple things like, you know, the best treatment for blood pressure, high blood pressure in a stroke patient is to stick a Foley in them, because they've usually been lying down on the ground for an hour, 2 hours, right? Hemiplegic, can't get to the toilet. Their frontal lobe still works, so they maintain bladder control, and yet they need to pee, and so their blood pressure goes up. And then simple restraints for the arms is often really, really helpful. Last couple of slides here, just to say that, you know, there's no doubt that really good stroke unit care after the procedure is critical as well. And we've looked at this in the trials. And if you look at patients, for example, who have small infarcts after treatment and then have a bad outcome, one of the key reasons is that they had a complication post procedure, like day 2 or day 3, they were intubated, they got pneumonia, or, you know, they developed a sepsis from a urinary catheter, or whatever it was. They had some complication, and some of those are unavoidable. I totally understand that, but excellence in stroke unit care is going to be really, really important. So summary then, really, you know, my philosophy at the moment with the current data is that we really want to use combined medical thrombolysis and EVT together. There seem to be lots of bits of evidence which support the fact that they're synergistic. I think procedural excellence is really going to be important, because you need TICI-3 to get the best outcomes. And finally, both peri-procedural, whether using GA, sedation, et cetera, and post-procedure care are really important to outcomes. And I'll say the last thing, you know, and I think maybe Darshan, you can tell us what you thought of VAR stuff, but stroke is like cricket. There's no I in team, right? It's not about one person's ego, or the endovascular person versus the neurologist who's taking, or the general physician who's taking care of the patient on the stroke unit. All 11 members of the team contribute. And I think that's the final thing, right? It really is a team sport. Okay, so I'll stop there and then be happy to take any questions.
Thank you so much, Mike. Yeah, as you said, it's a teamwork. So whenever an acute stroke comes to Calgary EMS, I guess almost 20 people must be activated at the same time, right? From the EMS crew to the nurses to the fellows to the consultant, neurointervention, everyone works as a team. So
Start your video.
Yeah.
And
okay, I got to figure out how to do that, buddy.
Stop sharing the screen.
There we go. Okay, good. Video's on. Can you see me? Do you want me to stop sharing the screen and then, yeah, there we go. How's that?
Yeah, fantastic.
Okay.
So we have quite a bit of questions in the Q&A section.
Yeah, do you want me to go through those?
Yeah, so Dr. Deepak asks whether tenecteplase or alteplase, what is the preference?
Yeah, so great question. I mean, I think, you know, I think the data are leaning all towards the tenecteplase is going to be where we're going to go. Yeah, I can tell you it may depend on your jurisdiction. So in Canada, we don't have a sort of a regulatory license to use tenecteplase for stroke. So we're generally only applying tenecteplase in clinical trials right now, and we're participating in some of those trials. My guess is that but I know that there are hospitals, for example, that don't stock alteplase and they only have tenecteplase available. So in that setting, sure, I would use tenecteplase if that's what you have in your place, 0.25 per kilo. It's easier, cheaper, potentially cheaper because of you don't have all the nursing stuff and the IVs. I think we're going there, but do we have definitive evidence at the moment? Not yet.
Fantastic. Dr. Priyanka asked about M2, M3 thrombectomy, about the
Yeah.
success.
Yeah, so I did talk a little bit about that in the talk, and I think we're going there, but we're going to do a trial. So we're going to do some trials and have a look at it. I do think there's a trial is needed mostly to understand the balance of risk and benefit. I have no doubt that opening arteries is a really, really good idea, but I don't know the risk in this scenario, and it may also depend on the technical side, right? So, we need small level stent retrievers to be able to do it, and they're just coming out now. So it may be that as this technical change and technical engineering improvement in the devices improves, it'll be really straightforward to proceed with that. So we'll see.
So Dr. Saurabh Bansal asked if the patient has an M1 LVO with low NIHSS and patient is in window.
What do you do, right? So, I don't know the answer to this because it rests in the balance about how effectively and safely you can do the procedure, right? Because if you have a complication in this scenario, all right, you can make somebody substantially worse, and that's always the case. It's true with thrombolytics as well. If you're going to give, say tenecteplase in the Tempo 2 trial in this scenario, you can make someone substantially worse. So the answer is it's still out. The jury's still out, and if you look at, all I can tell you is that the data that I've seen so far, the biggest data was from Nagar-Asdagi in Miami. The death rate from endovascular was around 4%, and the overall benefit for these patients was about the same. So it looks like it hangs in the balance to me on average. I think it'll depend on the scenario, right? Sometimes you make a judgment that a particular person with their particular occupation and their particular status in life, an NIH of 4 is really disabling for them, in which case, yeah, of course that makes sense to treat them because you're trying to reduce that disability. So I think it takes a lot of judgment, and I don't think you can say as a blanket statement you should be treating everybody in that scenario.
Yeah, that's true. And Dr. Shripal asked, how late can we intervene for basilar artery thrombosis?
I don't think there's a time window anymore for any stroke. It's about what does the imaging look like and what is the patient like, and there are some patients with basilar stenosis, it's all done, or basilar occlusion, it's all done in 2 hours, right? And by the time you get them, their pons and midbrain are all infarcted and it's too late. And there are some patients you can treat at 2 days and they still benefit, right? So I don't think that you can anymore. Really, you can use, even for any stroke, you can truly use time as a single threshold. It no longer applies. You have to use the combination of clinical judgment, imaging, time, status of the patient, what kind of family they have, and all those things.
Yeah. And if you have a good aspects of 10 and you have on CT, do you still require a CTA?
Well, that's a question about resource use in some ways. I mean, I think and I did say this in the talk I'm just trying to tantalize you a little bit, I suppose. I do think there are certainly situations where you can look at a plain CT and that's actually all you need to make a decision. You've got a good aspects, you've got a hyperdense M1 occlusion, that's it, go, right? Go, treat. But to some extent it's a resource use issue. So people are proposing we should go direct to angio, direct to cath lab without even a CT, right? Do the Dyna CT on the angio table, and many people have proposed that. And that's fine if you have a cath lab available to do that, and that's an expensive proposition, right? So we always do a CTA in our place because we don't have a cath lab where we can do that kind of thing. Other things have to be done in that cath lab. So we need to have a 100% probability that there's an occlusion that we're actually going to treat before we activate our cath lab team, and that's a resource use question. And I think so you can answer that question yourself based on your local available resource.
Again, a question, type of thrombectomy, aspiration versus stent retriever.
Again, I think you can take a utilitarian approach to this, right? Which is that what matters is TICI-3 reperfusion fast. So you work backwards and say, well, how good am I with this catheter or that catheter? I think it's a technical question for the interventionalist to say, what am I most comfortable with, and what can I get TICI-3 reperfusion with in the fastest possible time? Overall, I think the global experience is that everybody's using them together now. There isn't an or. You put up a big balloon guide, and you have a distal access catheter, and ideally you open a stent, you put your suction device at the face of the thrombus, and you retrieve the stent with suction under flow control with your balloon guide catheter, and that's the best way to get first pass reperfusion. But look, I think this situation I'm describing, it doesn't apply to all types of thrombi and locations of thrombi, and it depends on where you are, and you can't put a balloon guide in the basilar and like all that kind of stuff, right? So there's lots of technical considerations, and I think the interventionalist has to make a decision based on the technical anatomy situation, their comfort level, available catheters. But I would work backwards from take the utilitarian approach, work backwards from what the goal is, and make your decision on that basis.
Okay, we've got lots of questions, so I'm going to randomly select a few which I think might be important. So Dr. Kayo is asking, what's your strategy for patients with M1 occlusion but low NIHs? And somebody else,
I think
similarly asking, if you have a TIA, somebody's got a no deficit or very small deficit, but he still has an M1 occlusion, what would you do?
Probably I wouldn't treat him, right? I mean, in Calgary, what I would do is we would enroll them in the Tempo 2 trial, which is a trial we're giving tenecteplase or aspirin to patients like this who've got completely better. It's interesting that one of the first case series that I ever participated in writing up was a case series of M1 occlusions with minor stroke, and 7 out of 8 of them did fine, right? With conservative therapy. So we still have to be doctors, basically, right? We get to use our clinical judgment here and see what's happening. If the patient in front of you is totally well, you don't have to act right away. You have time. So take your time, consider the situation, try to understand the physiology, what's going on. The other thing you can do is just watch somebody. So they got an M1 occlusion, they're totally better. So, I guess the first things I often ask are they really totally better? Right? Because subtle neurology takes a little bit of time. So take your time and examine the patient and really understand, are they better, right? So get a good understanding. And then the second thing is you can just watch them, put them in your stroke unit, and every hour you get an exam, you get the nurses and stuff to examine them, and any sign of deterioration, treat them. And you have time because the brain is protected, right? There's no large infarct because they're clinically well, right?
Yeah. There's one more. If there's someone having a rapidly improving TIA, NIH is high and then he's improving, do we thrombolize that patient or not?
Yeah, that's a great question. I think, again, understand what's going on. So I think the general thing is rapidly improving is totally different from improved, right? So if you have an NIH of 15, when you arrive and then, you take the patient to the scanner and now they're an NIH of 8. Well, there's still an NIH of 8 and it's still disabling. So, give the juice, right? Treat them. Right. It doesn't matter that they got better from 15 to 8. You don't stop. You still got to make them better. And in fact, those patients might be great candidates for treatment because often what's happened is the thrombus is migrated or it's partially occlusive or there's enough collateral flow that they don't have a big stroke. So actually these might be the best candidates to thrombolyse. If someone's gotten completely better, NIH is 0 and they have no deficits, well, then we're back to that same question of, right, if they've got an occlusion, do you still treat them with 0, just like we discussed? And I think it takes a lot of judgment.
Yeah.
Dr. Subhash Kaul is asked, in a wake-up or unknown onset stroke, does even a very subtle flare hyperintensity rule out IV thrombolysis? He's talking about IV thrombolysis.
No. No, it doesn't. Right. I mean, I think if you're going to use MR and sort like they did in Wake Up, right, was they looked for that flare diffusion mismatch. But I think the answer is no, right? If you have a very small lesion, you don't have to withhold therapy, particularly if the patient's disabled, right? There's risk though, right? I mean, I think that most of the issue is helping patients understand that if you do this 2 times out of 100, you're gonna have a hemorrhage, right? And I'll tell you, this is what we've been showing in Tempo 2, which is the minor stroke and occlusion study, that there is a 2% hemorrhage rate even in minor strokes, and you have to decide, is that a risk worth taking? And in many cases, yes. The answer is yes. You want to treat them; they're disabled, so treat them.
Sure.
Darshan.
So there was one more question, like regarding blood pressure management in patients thrombolized and patients who are not thrombolized, patient reperfused, and as compared to patient on conservative management.
Yeah, no, great question. I mean, we don't have data on this, but here's my physiological approach is this: that a couple of things. So if you look at the natural history, once you've opened up the artery, very often blood pressure drops on its own, right? So you'll find that someone had M1 occlusion, their blood pressure was 180 systolic. You treat them and you've left the blood pressure alone, and then 2 hours later on the stroke unit, their blood pressure is 140. So it comes down. And then you've also done 2 things usually: put a Foley in and drain their bladder, right? And the second thing is you've opened the artery and it comes down. So generally speaking, that's what we do. Now, if it doesn't come down and the artery has been opened, I tend to be aggressive about using beta blockers to bring the pressure down and slow the rate of rise of blood pressure. Just like if you're treating an aortic dissection, you would beta block the patient to prevent worsening of the dissection. And the concept is that if the artery is open, it's great to get the blood pressure down. Same as you do, post carotid endart or stenting. You don't want that hyperperfusion syndrome. You want to bring the pressure down. So we do. I definitely do that. I find though that I don't need to do it very often. The prevalence of the need to treat blood pressure after you've got the artery open is low. The converse, if you treating conservatively, is I leave the blood pressure alone, let it ride to 180, 200 I just let it ride. And the reason is I regard this as a physiological response to stroke. We want the blood pressure to let it go. I don't treat it. I often spend a lot of time getting the emergency physicians not to treat the stroke, because the first reaction they get is, oh, this is a neurological or hypertensive emergency. And in fact, it's actually completely the wrong thing to do to bring the blood pressure down when you have an acute stroke.
Do you do the alternate? Do you push up the blood pressure sometimes? If it is around 120 systolic, do you take it to 140?
Yeah, I think Sudhir, that's a great question. I think people have done that, but I think in general I take the other approach, which is the problem is that there's a blocked artery. So let's deal with the problem, right? Let's not sort of play around the edges by
I'm talking about the blood pressure. So suppose there's no large vessel, it's only probably a lacunar stroke.
No, we've talked about that, but I don't know what to do with lacunes, right? And those kind of lacunar strokes. I've not seen a really good evidence of data that it makes a huge difference. We have done it sometimes, but again, really, really, really rarely, Sudhir.
Okay. There's one question somebody is saying it has to be put. Do you prefer CT or MRI for aspect score?
Well, you can use both, but we use CT because we use CT not by preference of the aspects, but because it's faster, right? So, we can do a non-contrast CT and multi-phase CTA and get information in 7 or 8 minutes. And we just can't do it that fast in MR. You just lose time. So we've in general, what we've done in Calgary is we've used CT for acute imaging, and we've reserved MRI for the follow-up imaging after. And we found that that's been the most useful, features of MR to understand, multiple emboli and, what the pattern of infarction is. using MR acutely, we have found not to be terribly useful. Now, we haven't pushed it in our place. Like, we haven't really pushed it to make it super fast. So, I understand that if people are using MR, it's certainly fine to do so, but really look at your times and ask yourself, are you fast enough if you use MR?
I think the last two questions, and maybe there are many questions more. So I think, Darshan, maybe you can give out your email, ask the people to send the question to you, and then you can forward it to Michael later.
Okay, sure.
Definitely. There's one more question is like, nowadays go for direct thrombectomy instead of giving the juice first. So in that case, what would you prefer?
Well, I think the jury's out on this. I'll just give you I'll try to give you a balanced view. I mean, I think, first of all, generally speaking, treat with both, because if you can, you probably get benefit. A very small percentage of people will open, just with the thrombolysis, and then you saved yourself a procedure. If you go to do the procedure as well, and then there's this idea that the thrombolysis, thrombolytics will help mop up any distal emboli, and I think that's an important thing as well. There may well be, however, some patients, and we may be able to select this by what's called thrombus perviousness. So on CT, you can, with advanced processing, you can identify which thrombi are going to be highly resistant to thrombolysis, and which are going to be the ones that'll be likely to reperfuse with thrombolysis alone. And it may be that we could select those that are going to be obviously resistant, avoid the lytic, and gain the benefit of the potential benefit of a lower risk of trouble with bleeding, for example. I don't know. I mean, one thing to consider is that as we move, and a lot of your colleagues here in India will be already have moved to tenecteplase because it's available from a local source. As we move to tenecteplase, which has a bit much higher fibrin specificity, it doesn't result in a systemic defibrinogenated state, that we may find that it's just like apixaban is, right? It's like aspirin. It's so safe that we might as well use it. I don't know yet, and we're going to see. I am very worried about not very worried, but I would just point out that the trials, Mr. Clean Direct, Swift Direct, I think there's a couple other ones being done as well, are unfortunately all going to be underpowered to answer this question. We're not going to we'll get some information, but it's not going to be definitive enough to make a decision. Nevertheless, the bottom line is, again, if you take the utilitarian approach, the bottom line we want at the end of our interventions we want an open artery, and we want TICI-3, and we want it fast. And we got to decide what are the best ways to achieve that. And most often at the current state, I would say it's a combined approach. But we may see that we can select over time as the data become available. We may be able to select some patients who clearly we only want the endovascular approach, and other patients we want a combined approach.
Fantastic. And last one, Mike, in a patient with ICAD, a patient having repeated occlusions on table, what do you do?
Yeah, so super challenging, right? I would say, about 10% of our patients, we have ICAD. You may have a bit more in South Asia, where you are, and I know the Koreans and Japanese, Chinese have a little more potentially. So it's super challenging. We don't have good stents, as you know, for this scenario. I think if I can just quote some of the experience from Korea. What they tend to do is use a tirofiban infusion. So they will try to open the artery, and then they'll use, a 2B3A inhibitor. You can also use eptifibatide, and they'll do an intra-arterial eptifibatide infusion, and then leave an intravenous one after. There's risk, right? Which is that you're interfering with antiplatelets, and you may have an increased risk of hemorrhage in that scenario. Super challenging. I mean, some people have left some of the solitaire AB can be left in place, right? It can be detached with an electrolytic break in the device. And of course, the Solitaire AB was meant for aneurysm coiling. I don't know whether you guys have that available. We have it in Canada, so you can actually leave a Solitaire in place. But remember, the Solitaire is it's only a partially closed stent, so it has very little radial force to keep open an atherosclerotic plaque. There are a couple of stents that people have used. Obviously, there's the what was the stent used in Sampras? It's gone out of my head. But anyway, then there are some coronary stents that you could try using as well. But I think we just don't have good data and don't know. So I don't have great answers for that.
Yeah, we have many questions, but thank you, Mike.
Okay, nice to talk to you guys. Stay well and healthy amid all this virus stuff.
Yeah, same to you. Take care.
Okay. Bye-bye.
Bye.
Have a nice day. Thank you. I have written Darshan's email in the chat, so you people can copy it and email him, and he will try to get the answers from Mike. Thank you and good night. I think you should sleep well, because we have another webinar on sleep in the morning at 9:30. Dr. Joy Desai is going to talk about it.